we're going to look at care registration and clinical management. Clinical management is grouped into several types of management. We have clients who were referred for HIV care and treatment. We have clients who are referred for TB care and treatment, and those who are referred for pre or post-exposure prophylaxis or other STDs. Now, the structure that we have on the system is to have one referral for any client who is HIV positive. You will not need to refer for TB or other STIs. I will log in to show that. During the referral, you have refer new HIV case for care registration and management. You have refer new TB case for treatment and management, and you have refer other treatment and management. Refer for other treatments and management, which means for prevention, for STDs, and for viral hepatitis. When a client is HIV positive, regardless of the category of the client, you want to refer for HIV. Ignore referral for TB or other STDs, regardless of the screening results for those other conditions. HIV on the system takes priority so that once a client is registered for HIV care, the clinical management team will have access to all care cards, TB, and other STDs. But this relates to an adult client. For a pediatric client, when you refer for HIV and the pediatric client has TB also, the system will automatically give you access to both HIV and TB. But if the pediatric client, and when I say pediatric on this system, I mean any child who is HIV positive but not an exposed infant or did not come in as an exposed infant. So that child will need to be referred for other treatment and management in the event that the child has HIV with other STDs. HIV and TB, you do not need to do a TB referral. For exposed infants, once you register an exposed infant, the system generates every form for HIV exposure, for syphilis exposure, for viral hepatitis exposure, and also automatically adds tuberculosis for an exposed infant. So for exposed infants, one registration does it all. For adults, refer for HIV if the client has HIV plus other infections. For pediatric, if the pediatric child has HIV and other STIs, you refer for HIV and refer for others. On no condition should you refer for TB if HIV is part of the infection. You can do that, the system will allow, but it's a waste of time. Only when the client has TB and other STIs without HIV will you need to do the TB referral or other treatment referrals. So we're going to do that now so that we can see. So in yesterday's session, we tried to do referrals for the clients that is positive, and the majority of you worked with case 1. So you are going to continue with case 1 and continue the practice after today with your with the clients you created. I'm going to skip everything about case 1. I'm going to skip everything about case 2, and we are going to look at case 3. Case 3 is about Dorothy. She is 28 years old female. She came in for testing with her daughter, Princess. Her daughter is 3.5 years old. She is currently pregnant, and her gestation age is 38 weeks and 5 days. So according to the story, Dorothy was afraid that Princess might be HIV positive because 4 years ago, when she was pregnant with Princess, she was told she was HIV positive, but she never agreed to be registered into care, and she never had any intervention when Princess was born. Princess also had no ARV exposure. So now Dorothy is about to go into labor, and Princess is not developing properly. So Dorothy brought Princess into the health center for HIV testing. The story says that on assessment, the midwife found Dorothy 2 cm dilated, and she was asked to check into the maternity unit at the hospital. Dorothy and Princess were confirmed HIV positive and were immediately referred for care registration and management. Few hours later, Dorothy arrived at the hospital where her labor progressed rapidly. Jason was born, weighing 5.5 pounds, 45 cm length. The head circumference was 33 cm and the chest circumference 32 cm. Now we're going to start. This is the screening result for Dorothy after delivery of her child. So apart from being HIV positive and having syphilis, she also has bacterial vaginosis. She and Princess both had HIV and syphilis. So today we're going to look at Princess. Princess would have been referred from the site. And when you want to look at clients that are referred, you come to care registration and initial evaluation. Click on view HIV care referrals. On this page, you are going to find the list of all the clients who were referred from various testing sites but are not yet in care. Once you find a client on this list, it means that the client is not yet registered into care. Now, you see that the form is slightly changed to be in tabular form where you can export. If the testing site referred in error, so if you follow up after a duration of time and you don't find the clients and the testing site or the name of the person who referred is contacted, the person who referred is contacted, and the person says that the referral was in error or the referral was supposed to be something else, you can delete that referral from the list. So any name you see on this referral, and how you delete is clicking on the trash sign beside the name. So this gives you the list of all those who were referred for HIV care registration and management, but are not yet in care. Under the care registrations and initial evaluation, you have view TB care referrals. This will give you a list of all those who were referred for TB care and management. And because nobody has been referred for tuberculosis, you have nothing on the list. So if we go ahead to say we want to do a TB referral for a client on the system, we'll have that name on this list and we'll have a button to delete if it is in error. Also, you can view other care referrals, which gives you the list of all those who were referred for either they were exposed to other infections or they were referred for both either PrEP or PEP. Now, we have other care referrals here. And I want to switch into looking at the forms for hepatitis, for syphilis, and for viral hepatitis. For hepatitis, for syphilis, and for other STDs, management for an adult client. So I'm going to take this unique ID for this client that is referred for other management, and I will come back to my care registration and initial evaluation. And then I'm going to scroll down and you'll see 3 different types of registration. You have HIV care registration, and this is for adults, adolescents, and pediatric. We have TB care registration, and we have other care registration. This person was referred for other management, so I must use the other care registration. If you use either of the other 2, the system will not find a registration form because that client was not referred for other management. So because we have this client referred for other services, I'm going to put in the date and click on register. Now the client has been registered into care. Once you register the client into care, you'll find that that client is no longer on the list because the client is now in care. If you come back to care registration and initial evaluation, You will find at the end of the list, registered clients orders. If you click on this, you will get a list of all the clients who are registered for other services, and you'll find who we just registered here. Once you are done with registration, if the registration is for order management, you can choose to give the client an appointment, send the client for psychosocial support, or just go to clinical management and click on order care card. And then you enter the unique ID and get care card. This gives you the care card for management of hepatitis, syphilis, and all other STDs. This form has been filled for the clients previously. So I'm using a unique ID that was used previously, and we can see that we have the hepatitis registration information. If the client does not have hepatitis, do not fill the registration form for hepatitis. You only fill forms based on the conditions that the client has. If the client doesn't have hepatitis but has syphilis or chlamydia or gonorrhea or any other STD, then you use the fourth tab here and fill in what the client has. If the client has no condition but was referred for pre-exposure or post-exposure prophylaxis, you skip all the tabs and just go straight to treatment. In treatment, you select the drug regimen or the drug you're going to use. You choose the line of drug. You put in the dose, the duration, and any notes you want to leave there. Now, this was previously filled, and we can see here that we have the list of medication that was prescribed. So a prescription form was given to this client, and this client is going to go to the pharmacy to collect this medication. Any question before I go on? Okay. Once a client is on any medication, there's a treatment monitoring form where you can select the type of screening. So if this client is the client on medications that can cause renal problems or liver problems, you might want to do your renal panel or whatever screenings you do. And you put in the screening you are going to do, you plan to do on the client when the client is on the medication, the date that you are requesting this, or the date you are sending the client to the lab. And then you put in awaiting results or the result of that screening if the result has been returned. Before we continue with this client, and I'll come back to this client, let us look at how the central medical stores and the pharmacy functions. And then we'll come back to these clients to see what happens with the treatment of these clients at the pharmacy. So what we are doing this morning, what we've done so far, is to look at how the clients who has been referred for other services, not HIV, not TB, viral hepatitis, syphilis, or other STDs, how it flows on the system. You go from referral, you go to registration of referral based on the type of referral that was done. So you are going to register HIV if the referral was for HIV care. You are going to do TB care registration if it's just for TB care. You are going to do other care registration if the referral is for anything that is not HIV or TB. Once you are done with that, for other care, you can skip all the other steps, come to clinical management, and go straight to other care card. If you want to keep things organized, you can go to appointments/patient monitoring and schedule an appointment and take vital signs before you come to the care card. But for other care card, the system allows you to bypass those processes. Let's look at the central medical stores. Dispense of medication starts with the central medical stores or supply.
Just making sure I get what you're saying.
Okay.
So do you have to register the other cases that are referred, or you could just go straight to the clinical? Do we have a choice?
Yeah, for anybody whose care card you want to retrieve, the person must be registered. So you must register everybody first. You must register the person. I mean, you must register the particular client whose care card you want.
Okay.
Yeah. But
Mildred,
for, yeah.
Sorry, go ahead. Sorry, I thought you were finished.
No, that's okay.
Oh, one of the things I came across a challenge at one time when I was doing the quiz. So we registered the client, we did the referral, we kind of figured that out after the fact, and registered the client in order for us to get to the card. Now, one of the things that keep popping up, because you had mentioned earlier on, the system allows you to bypass, I believe, one of the features, the appointment feature, if you just want to go straight into the clinical management. And I may be mistaken, but we were getting this pop-up that keep telling us, the client is registered, or the client vital signs were not registered, or something to that effect, that was not permitting us to continue with the client, the client case. Why was that? Could you just help break that down? Thanks.
Because the registration was for HIV care. Now I say you can only bypass if it's for other care.
Oh.
So if you register for HIV care, you must go through all the processes to get to care card. It's stricter.
So I have to do the appointment and patient monitoring before I can get to the care card.
Yes.
Wow.
For HIV clients, yeah. For anything that is not HIV, you can skip from registration straight to care card.
Okay.
Now, the reason that structure is like that is if you have a private place that is dealing with other STDs and is going to use the system, you want the clients to have a choice whether they want to talk about their HIV status or not. And so you want to bypass everything and give them just the clinical management for that care card permission. And so it doesn't stall the process for them to have all of those staffing to be able to get to care card for things that are not HIV. So that's the reason why that structure is like that, to accommodate private or in events where you go to separate clinics for the different treatment. But what happens in every treatment is that once a client is registered on this system, every medication the client has collected from the pharmacy will be logged here. Every drug that has been prescribed will be logged there, regardless of where it was prescribed. If it was prescribed at the HIV clinic, whoever is looking at these other treatments will see that the client is taking this particular medication, and the reason is to prevent drug-drug interaction or prescribing something the client already has or might interact negatively with what the client is presently taking. Now, for us to be able to see how the system logs dispense of medication, we have to start with the central medical store and supplies. Every user who is assigned the central medical unit permission will have this menu on their list of menus here. They have access to look at the list of all the registered pharmacies that dispenses ARV. You might also put in, or you can also put in pharmacies that dispense other medications that are not ARV. The system will allow you. But since the primary purpose was for HIV, you just labeled it that way. The central medical store will have to create the medication list. Whatever medication central medical store has not entered on the system, the pharmacy will never be able to add to their stock. So we want to create medication stock. Let's say we want to add a particular stock here. Let me put March 2022. Name of ARV medication, but this time I don't want to put in an ARV. I want to put in a medication that is on one of the prescriptions so that we can test it. So I'm going to put the name of medication, the form of the medication. So this is going to be injection. The strength, let's say 2.5. The manufacturer, I'm going to randomly put a manufacturer, even if they don't manufacture that drug. Expiry date. So let's make the expiry date on the 14th of September, 2022. The batch number, let me use this STI 090. The quantity. So let's say we're going to have 100 of this. The packaging, let's look at PVC. Amount in the pack, let's put 1. Or in a pack, we have 2.5 million units in one pack. So we have added this to the list of stocks that the Central Medical Store has. I'm going to add another medication here. And this medication now is doxycycline. The form is tablet, or let's say, okay, tablet or capsule. The strength is 100 milligram. The manufacturer, I'll select anything here. I'll put the expiry dates to be 9th of December, 2024. And the batch number to be STI 088. The quantity is 1,000. The packaging is blister pack. And let's say the amount in the pack is 30. Yes, Dr. Peters?
Mildred, sorry, I may have missed something. Under which subheading does this come?
So it comes, so when you go to pages, you go to Central Medical Store and Supplies, and then you come to create medication stock.
Oh.
So
okay.
this is a function for Central Medical Store. They have to create the physical stock that they have here. And then after creation of stock, and they've entered all of their stock, it is time for them to now look at the list of medications they have in stock and the quantity. So every time they distribute to a pharmacy and they record the distribution, it is going to be deducted from this quantity until it's 0, and then it leaves this list as stock out.
Okay,
now,
thanks.
yeah. So now we can come back to Central Medical Store and Supply, and we want to go to record distribution. I want to distribute these medications to my current pharmacy. So let's say Pharmacy St. Lucia. The quantity in stock is 100, and I want to supply, let's say, 10 to my pharmacy. And when I got there, somebody named James John received. And I'll click on distribute. Now, if I look at that medication, it was 100, but I gave out 10, so I have 90 more left. I can select another pharmacy and send that medication to that pharmacy. I want to give doxycycline capsule to the same pharmacy, and they have 1,000 in stock, and I'm going to give out let's say I'm giving out 200, and somebody named Imelda James received. So I have sent these two medications to the pharmacy. Now I'm going to come back to this and we'll look at the last functionality of central medical store. Once you record the stock at the central medical store and you record this stock in error, or if for any reason the medication entered has been recalled, you can come to view or recall medication, which is edit/recall stock. And then it will bring you to this page where you see the list of all the stock that you have entered into the system. If you want to edit the form of the medication, or the name, or the strength, or the batch number, or the or you want to recall, you will select here. The buttons at the end of each row only works for the row where the button resides. So if I want to edit this row and I finish changing my entries, I must click on this edit button beside. If I want to delete this completely, I will have to click, let's say, error in entry, and then click on the red recall button. Somebody was talking? Okay. So this is where you delete entries that are made in error. And this is also where you recall medications. Maybe it has adverse drug reaction. You want to recall distribution of this medication. You click on adverse, and it takes it off the list of medications you can recall. But the system will now have a log that you had this in stock, but it was recalled. And if you want to view that, you will look at view recalled, and this will give you the list of everything that was recalled. So I'll recall one for you to see how it works. So let's say this particular medication is potentially, so let's say this particular medication is expired. I no longer want to distribute this. I'm going to press the recall button. And because I have recalled it, it is going to go off the list that I have. Because right now, that particular drug of 150 milligram strength is no longer here. But when I come back here to look at central medical supplies and I go to view recalled, I'm going to see that medication on the list, the name of the person who recalled, the reason for recall. So there are several reasons there on the drop-down menu. If it expired, if by manufacturer, if there's error in entry, but you have it here. This is all the functionality of the central medical store. The system calculates your stock. When you delete it, balance it back. When you distribute it, deduct. So the calculation is accurate. You can try them out later on. Everybody has the central medical store and supplies permission for this demonstration. When these medications are distributed, the pharmacist with the pharmacy permission will click on the pharmacy menu here. A pharmacist can create stock, can view stock, can view recalled, can dispense, can print out labels for the medication that they want to dispense, can view all transaction history, can look at client's treatment plan, and can also view client's prescription history. Now let's create stock. The same way the central medical store creates their stock is the same way the pharmacy will create a stock of the supplies received. So that in the end, if there's a mistake, it can be traced. The pharmacy stock and the central medical stock must balance. So we'll put this date. And let's say we received. Always make sure that the name of the pharmacy here is your current pharmacy. We received a medication, doxycycline. The strength was 100 milligram. The form was capsule. The manufacturer we used there was Milan Laboratories. The expiry date for the doxycycline was on the 9th of December. So your expiry date here must be exactly the same as that for the central medical store. If not, you won't be able to delete. The expiry date here must be equal to the expiry date when you dispense the medication. If not, if you make an error in dispensing, you will never be able to delete that error. The batch number we used was STI 088. The quantity that was received was, I think, 200. The packaging we said was blister pack. The amount per pack we used was 30. Then we received another stock. And the name of this one was penicillin. The strength we had was 2.5 million units, let's see. Okay. The form was injection. The manufacturer we used was Viv Healthcare. The expiry date we used was 14th of September, 2022. The batch number we used was STI 090. The quantity we received for this, we said was 10. And the packaging we used was PVC. The amount per pack, 2.5. So I've created a 2 stock that was received from Central Medical Store. The next thing you want to do when you enter your stock is to click on View Stock. At the bottom of this form is a table that holds the stock that we just created. And then you can edit the quantity if you entered it in error and click on the green edit sign, or you can recall to delete, or if you want to send it back if it's expired and use the red recall button. This form holds flags for the different categories of flags. We have the flag that is triggered when the stocks are running low. And this system defines low stock as anything less than 50 in stock. We have also the list of ARVs that are out of stock. Then you have access to viewing the medications that Central Medical Store has and their expiry dates. So any medication at Central Medical Store that they entered in their stock that is about to expire will come here. So you have the information if you want to order more medications or more drugs. You see what exactly they have that is expiring, and then you can decide your quantity by knowing ahead of time what it is they have and the expiry date. You won't see the list of all they have, but you're going to see the list of just those about to expire. And then this gives you the list of the medication in your current pharmacy that is about to expire also. About to expire on this system is triggered when you have 6 months or less to the date of expiry. So this page shows you where to view the stock you have and the alerts related to the stocks. And if you want to now dispense medications, you will come to dispense here. Yes, Janelle?
Mildred, question.
Yeah.
So one of the tabs asks for you to include or list the number of pharmacies that are dispensing ARVs.
Yeah.
Hypothetically speaking, we have a private pharmacy that is dispensing ARVs, not under government system. So possibly they are procuring their meds under their own procurement procedures. How can we at the national level include them into the system and not make them feel like we are intruding on what they have, or in quote unquote minding their business, and allow them to have that level of privacy. Because I mean, I understand for the national level, yes, knowing how much we have in stock and so forth, but all of this feature does that. If I enter a private pharmacy in there, can they view all of this on their own and not feel like we are seeing it too, and make them feel we're violating their privacy?
No, for private, you won't be able to do that. And that is because of the way the reporting indicators are. You want to know one of the reports or the major reports of pharmacy, you want to see stockouts in the country. And
Okay.
that is done from Central Medical, right? Before it is distributed. And if we want to put in private pharmacies that get their stocks privately or from overseas and import their own stocks, there is no how you will accurately tell when there is a national stockout based on the free medication, and pharmacies might be selling theirs, right?
Yes.
And so it's going to disrupt the whole pharmacy purpose or indicator. So if you have a pharmacy who dispenses ARV and want to submit reports, they might have to do theirs manually. But if they are going through the central medical stores, they can now decide to use the system. But only if your pharmacist switch their pharmacy to their pharmacy that they can see events. But the only thing you can see are the things to your assigned pharmacy. And since all pharmacies have the ability to reassign themselves to any pharmacy, then there's going to be that risk that people can assign themselves to any pharmacy they want and see what stock they have.
Okay, understood. So technically, the private pharmacies, if it is that they're dispensing ARVs, then it means that they would have to be procuring from the central stores as opposed to a private something, just so that we can monitor what's there.
Yes.
Okay, all right.
Yeah, so the system is not supposed to just be for public pharmacy, but the way the reporting indicators or the objective of this whole pharmacy is to be able to track both central and pharmacy. And so the only way we can track it is to tie them together so that the pharmacy depends on supplies from the central medical store. And so we can have an accurate view of stockouts, national stockout of medications. And then also the pharmacists can, if they don't have a particular stock, they can actually direct the clients to where they can get it within the government system or within part of the care system where records are accurately entered into the system. So for pharmacy is the only part of the system where you might not include private, except the private pharmacies purchase all their medications from central medical stores. So once you have created your stock, you can see your stock, everything is accurate. The next thing you want to do is to dispense the medication when the client comes in. So click on dispense and it brings us to this form. The last client we looked at, before I come back here, let's look at what was prescribed to that client. So the ID was SVG 500. Yeah. So under the treatment of this client, we have penicillin 1.2, weekly, one weekly, so 3 of this, and 100 milligram of this for 2 weeks, for 14 days. Okay. So we'll come back to pharmacy and we want to dispense this prescribed medication. The pharmacy that I'm currently assigned to is here by default. And if this is not my current pharmacy, I will go back to my home page and switch my pharmacy. The telephone number of the pharmacy, the prescriber's name, let's say the date of prescription is today, is yesterday, 2022. The unique ID of the client is SVG 500. The client type is order. So on the prescription form, the doctors will try to use unique IDs when they write the client's prescription. And you want to also put if the prescription is PEP, or HIV care or other care, so that when the pharmacist is filling in this, they will see this. Now, pharmacists are the ones who went against the prescription coming automatically. They want to get the hard copy of it. They don't want to go through printer problems or having to print. So they said if the doctors register what they're giving on the prescription on the system, the client should come with a paper form of prescription, and they, the pharmacist, will enter it here. The date of birth also of the client will be there. I will assume that this client was born this, but in real life, I would have the date of birth. The client is a male. The allergies the client has, let's say not listed. The name of medication. So you can see that the drop-down menu of the drug will only populate the drugs that we have in stock. And we only have these two in stock. So I want to give doxycycline 100 milligram capsule. The frequency is, what was the frequency? Once daily. And the quantity is 14. Direction for use. So let's say take 1 tablet. Once daily.
Twice daily.
Twice daily?
Twice daily.
Twice, yes.
Okay, so this will be 28. This will be, so take 1 tablet 2 times a day. Okay, now there was this there was this case on the psychiatric ward that when you say take 1 tablet 2 times a day, those people are very intelligent. They now say, should I take 1 tablet and divide it and use it 2 times a day? Or should I take 1 tablet and that tablet I should take 1 tablet in the morning and 1 in the night? Or I should take 1 tablet now and take the other one. There's no hour in between because the direction on the medication says take 1 tablet 2 times a day. So it's subject to any interpretation, right? So they now came up with this method of trying to spell it out for people who think that way. So yeah, so I mean, down the psychiatric ward, but it seems that they get more intelligent than the rest of us sometimes. And so say take 1 tablet in the morning and 1 tablet at night. So the pharmacist will have to spell it out properly because this is what will appear on the label that you put on the drug. At night with food. And then the date of dispense. The expiry date of the medication was 9th of December 2024. And then the drug was picked up by, let's say, Ronald James. So remarks, let's say dispense in full or whatever remarks. Save. Yeah. Before we save, take note that there is a prescription number that is automatically generated here. You can edit this to give your own prescription number that you can remember. So I can say SVG 500 401 for me to remember what this prescription number is. Then you save. Once this is saved, the form is cleared for you to put in the next prescription, to fill in the next drug. So I'm going to put in the date. The client code. The type, others. The date of birth, we put 1st of January, 1980. The sex of the client is male. The allergies not listed. The name of the drug now is penicillin. The strength is 2.5. The drug form is injection, but the prescription said 1.2. The frequency is a weekly medication, once weekly. Weekly. The quantity is 2. The dose or direction for use, 1.2 for 3 weeks. The date of dispense, the expiry date of this was 14th of September 2022. It was picked up by the same person, and the remarks dispense info. Yes, somebody raised hand.
Yes, Mildred.
Yeah.
Is there a possibility that in dispensing for the same person, that all we have to do is go to directly to name of drug? So is there a possibility that from name of pharmacy to allergies remains constant? We don't have to type it in for each drug that we're dispensing for the patient on that day. Is there something that can be done? Because if we have to dispense, for example, 15 medications, let's say that patient also has heart problems and diabetes, plus the OI prophylaxis, the ARV and treatment for syphilis. It means we have to go back for
15
each
times.
drug and enter all this information, the patient, the fixed information for the patient about 20 times or maybe 15 times. So is there a possibility that when dispensing for that patient on a particular day, for example, this fixed information remains, and the only thing, sorry for the interruption, the only thing that we need to update is from name of drug down to dose, etc., strength, etc. Because it's quite tiring to go back each time and fully name prescriptions, fibers, name, date of prescription, unique ID. And it's the same thing for the test. Last night I tried doing this scenario, and I realized each time I had to enter a test, I have to go right back to the page with the client's information and type on STI screening and start the whole process over again. I don't know, on these pages, there should be a possibility to just go directly to add test, add medication, add medication, add medication. Understand?
Yeah, it was that structure before, but I think for pharmacy, it was the Pharmacy Association that kicked against that because it doesn't go with their regulations or whatever it is that they use. So I had to redesign pharmacy to suit what they gave me. And what the pharmacy had said was that they enter drugs individually, although on the system sometimes they record once they dispense a medication for somebody once, they have the information of the phone number and the date of birth of the person already based on the pharmacy information system that they use. But they always have to do each drug one at a time on their systems because those things are error prone. So they do it. So that's how their structure runs in almost all the pharmacies on the national level. And so I had to redesign to change it from mass entry to one at a time. So that's that structure. And it was the pharmacists that were on the consultations when this was being built that suggested that we change the structure like this. Then for the screenings also, to prevent you from entering the same kind of screening twice, or to prevent you from just entering screenings in advance before you do them that you won't do, is just to make sure the data is clean. That's why you have to enter each screening one at a time, and you only enter it when there's a necessity. So if we let people enter several at the same time, we might get lazy to the point where we say, let's request rapid and request an ELISA test all at once. And then maybe the ELISA becomes not necessary. And then on those parts of the system, there are no delete buttons on the interface. Then we'll have a lot of data entry that are erroneous, that is going to cause a lot of problems. So I think one of the major things with this system that makes a lot of things a little stricter is because the reporting is automatic. And for automatic to be useful, the data has to be at least up to 99% clean. And so you can trust the reports are generated. And to get that done, we have to make a lot of things stricter so that when you get your report, you are sure that you can run with it without having to filter anything.
Okay, understood.
Mildred,
Yeah.
and to sort of add to what my colleague just recently pointed out, whereby I understand the strictness that needed to be applied in this situation, is there any way that, for instance, we have sex, date of birth, and a lot of these standard demographics. Is there any way that this particular form can be linked to the entry form? You know, when we're entering a client, and as such, it is just already there. You know, I mean, yes, we have to do the dispense form, but we don't have to type their name and their date of birth and their sex, because we are currently entering for a particular client. And if it is that we're currently, entering for this particular client, then at least can some linkage be made to their file, the file from the beginning that can just enter this data automatically.
Yes.
Maybe that can be some level of assistance.
Yes, that can be done. I think it's done in other parts of this pharmacy also,
Okay.
where you select the unique ID and then. But now the problem they now have is, it's still an issue of unique ID. When the doctors write the unique ID on the form, if the unique ID is absent, that is going to block pharmacy from dispensing. And so the form becomes a free form that is not tied, so that if somebody brings in a prescription from any other place that does not have a unique ID or the values, the pharmacy has a free field to be able to fill in these things without tying it to any form. Because once you tie, it's either you tie and you have to stick to the rule, or you don't tie so that the rules can be flexible.
Well, I mean, at this case, knowing that we are rolling out case-based surveillance, I believe that is a rule that we can implement, that whatever the unique ID is that the clinical care coordinator would have used to do her clinical management, she enters it on the form or the prescription as, you know, the ID that is being used, and take it to the pharmacist. The pharmacist would know that this is what this number or this alphanumeric code is for, and therefore use it to enter it into her system. So it's just I think a matter of letting the clinical care persons know that, okay, if we're going to do this, use it that way, so that the pharmacist can now be able to work a little bit more effectively once that ID is used.
Yeah, so I can actually link that everything from here, allergies, sex, date of birth, the type of clients, the unique ID, they can be automatically filled, and then you just put in the date of the prescription and other things, name of drugs. That's
providing that the other countries see it as beneficial, especially the medical care people and the pharmacists that are on the calls. That's providing that they see it as something that is going to help make the work a lot easier, you know, because I don't have to use it eventually, but.
Yeah. So I can actually simplify this as much as possible, that still keeps to what the pharmacy wants to see. And I will do that, and after this session, and maybe by Friday, we'll see the changes made here. So once you have dispensed, you know you need to put a label on the medication, right? And this is where you come to print label. You put in the prescription number and guest label. So it gives you the label, and you just click on print. Your printer should be attached to your system already, and then it prints out the label for you to put on the medication. So I'm going to cancel this and go back. So you do that for as many medications whose labels you want by putting the prescription number and getting the label to put on the medication. Then you come back to pharmacy here. Another suggestion the pharmacists made was that sometimes they need to look at the treatment plan of the clients when they want to give their counseling before they give the medication. For that, pharmacists have access to a client's treatment plan. So it only gives access to not the whole medical record of the client, but the form that was filled by the clinical care team for that clinical encounter for the particular day that the client has come. And if that form was not filled, you will get that message that there was no symptom review field for the client. If you want to look at the treatment history for clients also, the pharmacist can come to the treatment history page and put in the unique ID and see all of the medications that was dispensed for the client. So I'm going to update for the dates to show. So they can look at this to see all of the list of medications that the client has taken in the past or is currently taking or was just dispensed for the client. Then the pharmacist also can view all the dispense that has happened in that pharmacy by clicking on View All Transaction History. Now, the View Transaction History is the part of the system where the pharmacists come to delete any dispense that was done in error or that they need to reverse. So they just come here to that particular medication and click on the trash sign beside that row, and then this deletes that medication and balances back the stock based on the amount supplied here. Once this is done, the clinical care doctor now will now see on the care card of the client that the client has picked up the medication. And now the form changes to see that the prescription history, this has been dispensed at this pharmacy, and this was the date of the prescription, and this was the date of the dispense. And we have the medication name, the strength, the quantity, the frequency. And so once the treatment history here and the prescription history here are the same, it means that all the medications that were prescribed have been picked up by the client. And so if the client comes back and you don't see any table above the treatment form to show that the client has picked up the medication at the pharmacy, then you want to follow up to find out if the client is adherent because the client is not picking up medications, or if it is the pharmacist that did not enter the dispense. You want to find out. So this gives you a clear view of the duration of time between when a medication has been prescribed and when the client actually goes to the pharmacy to get that medication. So this is the importance of the pharmacist using the unique ID so that the system can link the dispense history on the treatment form of the client so that the clinical care team can see the drugs that were prescribed and the drugs that have been collected by the client. Any question before I go on?
Yes, Mildred, one question.
Yeah.
I'm just trying to figure out, from each country, you have to do an art report every 3 months. Okay. I'm just trying to figure out how that report fits in the case-based surveillance.
So what does that report hold?
Hello?
Hello, I said, what is what is the report supposed to produce?
Okay, the form, the indication on the forms are you have to fill in the patient, like their ID number, male, female, sex, when they started taking medication, what medication they're on, when they last pick up medication, how much months of medication they got, what is their viral load result and their CD4 result and the date that it was done. And that is the raw material, but then also they will need some summary information that they normally ask you for. But basically that is what the form is consist of. So I'm just wondering, how will that fit into this system?
Okay, you can email me the form and I can build that into pharmacy report. So once all you do is just download that report automatically. So if you send me the email of that form later this afternoon, I can actually build it on the pharmacy report to give you a table that has all the columns that you want for that report. So you won't need to calculate anything, you just print it out or export it to Excel.
Okay.
Yeah. So let's look at each of the form for other STDs. Now this is the treatment form. And for any part of the system where this client is being treated, if it's for the HIV clinic or the TB, you'll find the treatment history here. So regardless of who prescribed, the treatment form holds all of the treatments that has ever been registered on the system. And so if the client is receiving treatment anywhere else, the doctor will see that treatment here. Without having to see the care card, will know the drugs that the client is on and the drugs that the client has picked up. Now let's look at the first tab, which is the adult hepatitis registration form. If this adult had hepatitis and was referred for hepatitis treatment, you will fill in the hepatitis registration form. This form collects the registration date, information of whether the client is a pregnant client. If the client is pregnant, you want to enter the expected date of delivery. You want to fill in how the case was found. Is it through antenatal screening if it's for a pregnant client? Is it through contact tracing or based on clinical presentation of the client? The type of hepatitis that the client has, you select from A, B, C, E, G. The confirmation status, is this confirmed or is a probable case? Now, the type of screening that was done for the client before the client was confirmed, you're going to fill in the results here. You fill in just what screening was done. If you have not done any other screenings, just fill in the surface antigen. If you are doing for hepatitis C also, you fill that in. You want to also fill in information about other exposures. You want to put in the audit score for the client if there's any alcohol use disorder, if the client is diabetic, if the client has other conditions that makes the client that can actually make the clients have hepatitis. And you're going to look at the alpha-1 antitrypsin deficiency. You're going to look at Wilson disease, the autoimmune hepatitis. Primary, if the client has primary biliary cirrhosis, or if the client has hemochromatosis, and any of these ones the client has, you either answer yes or no to help with the reporting for hepatitis. If a client has hepatitis and the client is registered, you will come to the hepatitis diagnosis and diagnostic data or category. On this form, you put the date of confirmation. You put the, you want to put if this case meets, the confirmation of the case meets newly acquired, or it doesn't meet the criteria for newly acquired, or you don't know if it's newly acquired or not. You also want to look at the type of case, if it's a new diagnosis, if it's a case that needs a transplant, a liver transplant, or an end-stage disease, or it's the case of somebody who is already dead right now. The symptoms that the person has, you are going to put in the symptom. If not symptomatic, you select asymptomatic. If the client has symptoms, you select from the list of symptoms. You also want to look at any other symptom the client has and put the symptom here. You want to also look at the clinical diagnosis, if it's chronic hepatitis B, if it's acute hepatitis A, hepatitis C infection, or if it is a perinatal hepatitis B infection. And then if there's any other clinical diagnosis, you put that here. Now you want to look at the effects or the complications of the hepatitis if it's already an advanced case. We want to look at the diagnosis of cirrhosis and look at fill in the form for the difference if you have a clinical diagnosis of cirrhosis or an imaging diagnosis or a biopsy diagnosis. If it's based on the AST and ALT, you put in the AST and ALT value. If you do the test, you put in the platelet count. If a fibro test and a fibro scan is done, you put in their results also. Then you want to also get a cirrhosis score. And to get that score, you want to fill in the criteria or the points of each of the different criteria. Encephalopathy, you select if anyone is present and what the score is. Ascites, bilirubin value, the albumin also, and the prothrombin time. And the total from this will give you what total point or what stage of cirrhosis that the client is on. Then you fill in information for diagnosis of hepatocellular carcinoma. And if the client doesn't have this, you leave it blank or you feel no. And if the client has any of them, yes or not diagnosed. And then you save the form. But you use these forms for hepatitis only when a client has a confirmed case of hepatitis or a suspected case and is referred for hepatitis treatment. So once you register a client for hepatitis, you do the diagnosis and the category. You want to also put in the risk factors and the reason for test for the hepatitis client. This will also help for reporting of hepatitis, what the risk factors or the most prevalent risk factors for those who are positive you select, and the reason for test for the person who has just been diagnosed. Once you fill this three tab, you have done with the hepatitis. Anytime the client comes for follow-up visit, you continue to review these three forms until you finally put in the outcome of the treatment with the client is treatment is already successful or the client dies. If the client does not have hepatitis and is there for other STDs, including syphilis, you use the chancroid, the chlamydia, gonorrhea, herpes, syphilis, and PID form. On this form, you select the type of STD that the client has, either syphilis, chlamydia, gonorrhea, the stage for syphilis, or the stage or the type of chlamydia and or gonorrhea, if it's gonorrhea, and then other symptoms, if the client has other symptoms for other STDs. Once you've registered this, you can now go to the treatment to treat whatever you register the client for. Now again, if this client is coming in for pre-exposure or post-exposure, the only business you have with this form is treatment and treatment monitoring. All of the other forms are not relevant for people who are just there for pre or post, just treatment and treatment monitoring. So this is the functionality for treatment of viral hepatitis and other STDs and for prevention pre and post for an adult or an adolescent client. The pattern is when the client is referred for other management, we are going to register the client into care for other care management. We are going to go to the care card to see this. Once the client is sent with a prescription, the client goes to the pharmacy dispenses, and it shows up above the form here. Any question before I move to exposed infants?
Mildred?
Yes?
Question. So if on further testing or follow-ups at follow-up visits, this person is diagnosed positive with HIV, then do we have to go back and now do an HIV care registration? Okay, yes, I guess we'll have to do that. But when we do the HIV care registration, will all his previous hepatitis information be exported or added to the HIV care registration? Or do we have to go and fill in the whole hepatitis section in the HIV care registration all over again?
No, because HIV takes priority. Once the person is registered for HIV, all TB care card and this other care card, everything you see here will be added to the HIV care card automatically. So the treatment history that we already have here. So let's assume that, was this client registered for HIV before?
No.
Okay, so let's refer this same client for HIV now and see how it goes.
Okay.
So this is 16th of March, 2022. SBG 500, category is adults, and refer. So referral successful. So when we come to care registrations and initial evaluation, we view HIV care referrals. We should see that client's SBG 500 here, referred. Now this client is around in the clinic and we want to register the client into care. So you are going to go to HIV care registration for adults, adolescents, or pediatric. Okay. And then we put in that unique ID and get registration form. Now you select the date, which is today, the month, and the year, and then you click on register. For HIV now, if these clients had HIV first, you won't need to do the registration for others, but because the client had other first, and then during the treatment of others along the line, the client now has HIV. So you're coming back to refer HIV and to register into HIV care. In this case, HIV is stricter. Once you register HIV into care, you must come back to care registration and initial evaluation, regardless of the category of that client. You must do an initial evaluation. If the client is an adult, you want to go to adult, pregnant, and adolescent initial and clinical evaluation. If the child is a pediatric, you want to go to pediatric initial and clinical evaluation. If the client is an exposed infant, you want to go to HIV exposed infant evaluation. Now, this client is an adult, we'll go to adult, pediatric, and pregnant. Adult, pregnant, and adolescent initial evaluation. You put in the unique ID, you get the initial evaluation form. This initial evaluation form is always the first form you want to fill for the new clients that has just been registered into care. And for the first couple of months, when the client comes back, you will have to update the form to fill in all the baseline values that you might not have at the first visit. So the date confirmed positive. So let's assume this client was confirmed positive today. And the client was also enrolled today. And the age at enrollment is his current age, which is 42. This client has not previously been on ART, so I'm going to skip the prior ART regimen, the ART start date, and the key entry point, and I'll click on submit. Now I'll move to the baseline information. This form wants to collect the date started ART, the initial weight of the client on registration, the initial assumed clinical stage on registration, and then you want to collect the name of your treatment supporter or medication pickup if the client is too ill to come to clinic and the client wants to send in maybe a relative. You want to have that name on the list so that on the clinic day, if somebody represents the client just to come and get prescription, you'll be sure that it's the person that the client listed. And the relationship to that person, home-based care provider, if any, and this is where you list the drug allergies. So the client has not started ART. We're going to leave that blank. This client came in weighing 2 to 5.7 pounds, and the system will automatically convert this to kilograms. The initial clinical stage, he has hepatitis and he has everything. Let's say that he is on stage 3. Our assumption, this is not the real clinical staging, but this is the, based on the symptoms, this is like the assumed clinical stage. And then you want to put in the drug allergies. You don't know of anyone yet. No known allergies to drugs. and then you submit. Then now we want to fill in the dates of the first WHO clinical stage 1 or 2 diagnosis, the date of the first stage 3 diagnosis, and the date of the first stage 4. We never had a stage 1 or 2. We only have a stage 3 today. And so we'll put the date of today. If for any reason you didn't fill in what clinical stage you're assuming at the baseline information, you can skip this form and come back here during the next visit when you are sure, or at the end of the clinical management visit when you are sure of what it is you want to fill there. So you can always come back to edit this form. It retains the value, and anytime down the line, you can update the forms. So the CD4 information. Now, the most likely thing that will happen is that you'll be given a lab form for them to go and get the CD4 test done. And so you want to put in the date of request. And the date of first CD4 test should be your date of request until the result returns. And then you update this to be the date that is on the results that the client came in. So if you send the client for CD4 today and the client decides to go next week, Monday, then when the client returns or the result returns, the date of first CD4 test is going to be that Monday that the sample was taken. But for now, all you have is just a date that you requested that the client goes for the test, and you fill in that date here and fill in the same date, and you submit. So you do the same thing for the viral load, the date you are requesting viral load. And you put in the date of first viral load as the date you requested, hoping that the client goes today, but if not, when the result returns, you put in the date of the test and the value. But for now, all you have is your date of request. Once you are done with the initial evaluation, as a clinical care nurse, you are done with your job. It's time to send the client to see the clinical care coordinator, but the client needs to be ready to be placed on ART. You want to now do an initial, or you want to do an adherence readiness assessment. For every client who is going to be placed on ART, you want to send them to the adherence counselor, or you want to send them for psychosocial support. And to do that, you're going to come to psychosocial support / adherence counseling. So let's assume that the person who is going to be doing this now from here is the counselor. If you don't want to send them to the counselor first, you want to give them the appointment, you come to appointment / patient monitoring here, and then you come to schedule counseling appointment. You put in the unique ID of the client, and there are 3 types of adherence counseling. We have the adherence readiness assessment, we have the adherence strategy work plan, and we have the adherence follow-up assessment. For a new client who is waiting to be placed on ART, you want to start with the adherence readiness assessment. For a client who doesn't seem ready, but you want to make the client ready as soon as possible, you are going to go do the adherence strategy work plan. For a client who is coming on a returning visit after being placed on ART, you will do the adherence follow-up assessment. So let's schedule this for adherence readiness assessment, and the client has been referred. Now you can tell the client to go to the counselor's office, and the counseling session can start. The adherence counselor or the social worker is going to come to psychosocial support / adherence counseling and come straight to start counseling encounter and put in the unique ID of the client. They can verify if the client is on the list of clients with appointment, get form. These forms are generated based on the type of session that was selected when the appointment was scheduled. The form holds flags for when the last CD4 test was done and when the last viral load test was done. The system automatically sets the next CD4 test to be 3 months from the last and the next viral load test to be 6 months from the last. It is not a fixed rule that you must do it at that time, but the system uses flags to keep us in check and to remind us that in case you have a client who is completely non-adherent or who is not on ART, you might want to follow these timings to make sure you monitor the values. So the form for adherence readiness asks questions. This form is going to ask an adult client the questions directly, and for a pediatric client, the questions are going to be for the caregiver of the pediatric client. You can choose to use this process for TB for other care, but it is only required for HIV. You decide if you want to go through all this process if you are looking at the client with hepatitis or other treatments. How many sessions of pretreatment counseling did this client attend? So let's say this is the first one. Is the client's treatment literacy sufficient? Let's say yes. Does the client have any misconception about ARVs? And if yes, what are they? Let's say he is enlightened, he doesn't have any misconceptions. If he has, we'll put the misconceptions here. Has the client disclosed his or her status to anyone? Yes. Who? Let's say brother. Is this person supportive? Let's say yes. And if the person is not supportive, you give any assumed reason why the person is not supportive. Has the partner been tested for HIV? Let's say the client says yes. Is the partner taking acts if living with HIV? Let's say he says yes. And the clinic the partner goes to, let's us give any clinic. Does the client have children? If yes, you want to ask, have they been tested? And then you want to counsel on HIV testing for all children. So let's say no. And if the client has children, you want to put how many children have you done counseling for testing all children here? You're going to fill in that note here. Does the client have a treatment assistant? Let's say yes, and the person is the brother. So the brother and the treatment assistant has a contact. Did the treatment assistant take part in the pre-treatment adherence session? Let's say no. Does the client wish to be visited at home? We'll say yes, and we'll give the location of the house to be 25 Park Street. Just make up a name. How will you describe the client's mental state? So you're looking at the client, you are listening to how the client talks. I would say the client is looking anxious. Does the client fear discrimination or violence at home or in the community? Let's say yes, and then you want to counsel on how to get support or look for support groups around. So if you have support groups in the country, you can refer for support. If not, you want to counsel them on how to cope with the fear. Who does the client go to for support at home or in the community? So let's say the client goes to the brother for support at home. Does the client come to the clinic or his or her appointment dates? This is the first time, so we don't know yet. Has the client been adherent to other medications in the past? So this might not be the first time. The client was previously in the hepatitis treatment. And let's say in that treatment, the client always shows up. Has the client been adherent to other medications in the past? Let's say yes. Did you plan a drug timetable with the client? We'll say no. Is the client a member of the care and support group? We'll say no. Substance addiction, the client said she uses alcohol. Does the client feel confident about taking medications or giving children medication in the case of a caregiver for the rest of life? And the client feels confident. Who else takes care of the child other than the caregiver present? And this is going to be a question that should be answered only by the caregiver if the client is a child. Has the caregiver been trained? This is also for a pediatric client. Has the client had challenges taking other medications every day at the same time? Let's say no. Does the client know the names of the ARVs to be taken at the time? So at this time, you would have gone over the names that will be prescribed and the time on how the medications are taken. And if the client can repeat after you what they intend to place the client on to start with and the time, how it should be taken, then you are going to put yes, the client knows. If the client cannot remember or still gets confused, even if you have a sample bottle that is labeled according to what is going to be given, then you can say no. Does the client know the side effects of these medications? And you tell them the client's side effects, you counsel on side effects management. The client understands it, yes. If the client does not understand, no. Does the client know the consequences of not taking ARVs every day for life? You want to counsel on lifelong adherence. The client understands, yes. The client does not understand, no. You're not sure or none. Is a client on other medications other than the one prescribed by the doctor? And this includes either traditional or herbal medicine. And he says no. So you want to now do an assessment, your own assessment based on the questions, based on the response. What is your assessment of the client's readiness to start ACT? So let's say the client is ready. And then if there are questions or concerns that the client states, I'll put them in here. If there are other issues or notes that I noticed, I'll put it in here and then I'll save. And so the adherence counseling session is done and I have saved that session. And then it gives me a list of all those who still have an appointment for adherence counseling who have not been seen yet. Once I am done with this, it is time to come back to appointment/patient monitoring and schedule new clinical management appointments. I'll put in the ID SVG 500. The reason for appointment is HIV clinical management. And let's say the appointment is going to happen today. Once the client has an appointment, you will come back to appointment/patient monitoring and you come to create visit/record vital signs, put in the unique ID and start visit. Now, you must record the vital signs for HIV care management card to be released. So let's say he's very sick. His temperature is 39 degrees Celsius and it's automatically converted to Fahrenheit. His blood pressure, let's say, is 140/90. Just make up anything here. The pulse is 1. The respiratory rate is 25. His weight is 225.7. His height is 170 or 160. And his BMI is calculated automatically. Since this is an adult, we'll just send. Once this is done now, the doctor can now come to clinical management, look at the waiting clients list, and you see this client on the list for HIV clinical care. And so now you can come to HIV care card and get the care card. SVG 500. So on this form, and I'm going to change this to be graphical, like someone suggested during the trainings. I've not done that, but I remember that. So I'm going to change this to be a graph so that it will be easier to follow. You have the flags for when the next CD4 is due, when the next viral load is due. You also have the flag for the trend in CD4s and viral load. There is no record yet, so there's no trend. The trend in BMI, so we can see the BMI was 45.8 on 15th and was 40 on 16th. Can anybody lose 5 pounds overnight? Then the adherence assessment report is only going to be populated when a client is already on ARTS and has done the follow-up assessment. The drug resistance testing results will appear here when it is filled in. If you want to go and request new screenings or look at screening results, you click here to get to that page. The care card starts from today's encounter, where you have the basic demographic information. You have the vital signs that was just taken here. And if you have any need to repeat it, the first tab gives you the vital sign form on the left and the history of the vital signs that have been taken on the right. We have several forms, but now you can see that because this person is registered for HIV, you have all the HIV, all the TB, and all of the other forms. So look at what was filled at the other clinic for hepatitis automatically appears here. And this is the reason why there is no point referring for other treatments if the person has HIV, because the HIV care card is going to retrieve everything that the client has all around the system. So you get back everything that was done for other management included in the HIV care card. Now, during the trainings, I disabled this not to show up so that we don't get confused in the forms that we need. So because you have the hepatitis and others here, you can review the entries from the other clinic, or you can just go straight to your HIV. So the first HIV form here is the symptom review form. And this is the form where you fill in your plan, your presenting complaint, and anything for that management session. At every clinical management visit, you must fill this form. It is an encounter form. So once you fill it, every value on this form clears out for you to put in another value. It saves on the system where you can get the previous encounters, and you have a care card that shows you previous entries. And we'll go back to that later on. We have the TB symptom checklist, which is also included in the form for the TB symptomatic check for all HIV clients. This is where you update CD4 and viral load. If you have the results now at this visit for the CD4 tests and the viral load test values, you put them in here. The adult clinical staging, this is where you do the proper clinical staging based on the symptoms of the client. And if the client has, so you look at the symptoms and check all the symptoms that the client has. And then when you check them, you click on submit for the stage. We have the adverse HIV adverse drug effect, which is going to be filled if the client is on ARTS and the client complains of side effects. Now we have a mental health assessment and evaluation, which should be done also at every management visit, especially for clients on ARTS. And we've gone through this form severally during the training, but I'll quickly scan through this since this seems to be the most complicated of all the forms. On this form, you record the dates. You are going to select if the client in the last 3 months or 90 days, if the client has been incarcerated. Then you want to put in if the client is prescribed HIV medications, if the client is adherent to those medications, if the client is on any psychotropic medications, and if the client is adherent to those medications. Then you want to look at the drug use and sexual behaviors in the last 3 months. And you want to select if the client has had unprotected sex in the last 3 months, if the client has used illicit drugs in the last 3 months, or if the client has had sex without disclosing HIV status in the last 3 months. Then we have the category of mental disorders that you select what you think is the most dominant kind of mental disorder that you suspect based on the assessment that you are going to do here. So you can select this last after you've done the assessment. So we have the assessment measure form, which looks at 15 domains of mental disorders, and each domain holds a set of questions. And the questions you are asking this client is to see if any of these things have happened and the number of times it has happened within the last 2 weeks of the assessment. If the client has had any of these, you are going to record the highest domain score here. If it's 0, not at all, you always put 0. So there are 2 questions in the first domain. If the first question is 0, the second is 3. The highest domain score is 3. So you're going to fill that for every question here on the form, and then you save this information. We have the treatment form, which automatically gives you the treatment that was done at the other clinic. And so now you can start your HIV treatment here. So let's say we want to put this client on TDF, FTC, EFV. This is the first 9 treatments. The dose is 300, 200, 600. We want to give for 30 days first, and then we'll save. So now you have prescribed ART for this client. But if you look at the treatment form, ART was just prescribed. So there is no drug pickup yet until you go to the pharmacy, and then the pharmacy dispenses this, and then it shows up on the history of dispense form above. If this client now has HIV, the TB symptom checklist is the one that you do the symptomatic check at every visit. But the tuberculosis registration form should be used when there is a diagnosis of tuberculosis. If not, don't fill the tuberculosis registration form. For every HIV clinical management visit, the forms that you really have business with is the symptom review form, the TB symptom checklist form. You update CD4 or viral load information based on lab results availability. Then you look at the clinical staging of the client. If the client is on ART, you want to look at the adverse drug reaction. Then you do the mental health assessment. And if the client has any area of worry with the mental health, you want to do a referral to a psychiatrist, or if you are a psychiatrist, you just want to give a treatment and go to treatment. The rest of the forms after treatment depends on if the client has HIV co-infection or the client has opportunistic infections. But until then, you have no business with all the forms from tuberculosis registration down to the other STDs. So someone asked a question, can the functionalities and the sub-functionalities be placed at the top of each main form? I don't understand. Okay, you want the... So, Dr. Peters, you said... Yeah?
Okay. Sometimes I get lost.
Okay.
At the very top of the main form, like for example, this form which says, oh, I can't move it. But at the top of this form,
okay,
right, above today's a counter, could we have like the functionality if it's care and registration, and then next to the functionality have the sub-functionality. So more or less we're guided as to where we're working, because I'm not sure if we're still on the registration, or if we're actually in a clinical visit, or exactly where we are.
Okay, so
it's like each time one has to go back to pages and go on the pages to see where we're presently working. But if somewhere we're at the top.
Okay, I'll put that this is HIV care card.
Right.
Okay.
Yes, that would help.
Okay, so let me write that down. I'll do that today.
Thanks.
Okay. Any other question?
No, thank you.
Okay. So we can see that when a client is, okay, so Janelle said that was a question as well. All right, so I'll fix that later today. So we can see that when a client has HIV, you have access to all the forms. So you don't really need to actually go to TB care card or other care card since the client has HIV. So this is one of the reasons why I have said that there's no need to double register for HIV and for others or for TB if the client has HIV. HIV registration takes priority and gives you access to everything. Okay, so this is all about adult clinical management. Any question with the adult? The pediatric is exactly the same with two major exceptions. The symptom review form for a pediatric client is totally different. The clinical staging form for the pediatric is different. And then the pediatric client will not have hepatitis registration, hepatitis diagnosis, hepatitis risk factors, and for other STDs. And when I say pediatric clients, I mean all those clients who were not exposed infants, but who are pediatric HIV positive clients. So you're going to get all of these forms down to TB treatment outcome for pediatric. And I was going to try that, but I can leave that for you to try out. We try case 3, which is the case of Princess, and you refer her. You should see that if Princess happens to have syphilis or hepatitis, you will need to do a referral for others. So let's summarize how the system works. For an adult client who is HIV positive. Do we have another question? Dr. Peters, is your hand raised from the last time or this? Can you hear me?
Yes, we can hear.
Okay. All right. So I was saying that if the client is referred for management, for HIV management, and the same client is referred for TB management, and the same client is referred for other management, you can do a registration for HIV alone and delete the referral for TB and others, because this already gives you access to everything you're going to find at the other parts. If the client does not have HIV, but is referred for TB, if that client later has other STDs, you will need to refer for other STDs and then look at the other STD care card. So it is only when a client has HIV, that's for an adult client. It's only when an adult client has HIV that you have access to all the care cards in one. When the client is a pediatric client and the pediatric client has HIV, you have access to all of the HIV care card and the TB care card in one. If the client is an exposed infant and the exposed infant is registered, then the exposed infant has access to everything at once. So it's only the pediatric clients that will need other registration if the pediatric client ends up with other STDs or hepatitis. The exposed infant do not need any second referral or second registration. The adult who is registered for HIV care do not need any referrals or any other registration if they are in HIV care. Should we take a break or I should move to the last agenda directly?
A short break.
Okay, so we will take a 10-minute break. It's 11 o'clock. We'll come back at 11:10.
Thank you.
So the adult care card has all of the care card forms from adults, from HIV, TB, and other STIs, and the pediatric has all of the care card information from HIV and TB. Now we have looked at pediatric, we have looked at adults, adolescents, pregnant, but we have not looked at the exposed infants. And everything about the exposed infant is completely different from all we have seen so far. For the exposed infants, they are registered also by the clinical care nurse or anybody who has the care registration and initial evaluation permission. Before the master training, we had 2 separate exposed infant registration. So in order to simplify things now, we have just one form that registers exposed infants regardless of the exposure. So when you come to care registrations and initial evaluation, you go to HIV, syphilis, and hepatitis exposed infant registration. The form is the same. You fill in the dates. The name of the infant. Let's give an infant Susan. Susan's middle name is Mercy, and Susan's last name is Philip. Susan was born on the 2nd day of February 2022. Her mother's unique ID. Let's say we assume that we don't even know the ID. The Mother's maiden name, we don't know. The infant ID. Now let's come up with an ID for Susan. I'll say it's SUP 22F, and I'll assume that this is the birth certificate number or something. The health district, I'll say it's Health District St. Lucia Parish. Let me put Parish St. Lucia. The biological sex of this is female. The weight of this child at birth, let's say the child weighed 6.8 pounds. The child was 49 cm long, and the child is currently going through mixed feeding. And what is the infant exposed to? So this is the added field to differentiate the registration and keep it on one form. So the system now used this answer to send the data to the various tables where they need to be stored. So this infant, let's assume that the infant is only exposed to hepatitis, you select hepatitis. If the infant is exposed to HIV only, HIV, syphilis only, syphilis. Both HIV and syphilis, HIV and hepatitis, HIV and syphilis and hepatitis, hepatitis and syphilis. Whatever you select here does not restrict your form access, but it can affect your reporting if you want to see what different exposures that the children have. So if I want to count the number of people who were exposed to syphilis and you put HIV, this client will not be counted as a syphilis exposed infant during the reporting. So you want to accurately know what exposure you are registering the client for. So let's say this client is exposed to everything, and I'm going to register. Once you register an exposed infant, the form is cleared for you to register the next exposed infant. If you are done, you come back to care registration and initial evaluation. Like I said before, only when an exposed infant is exposed to HIV do you need to do the initial evaluation. So after registration of exposed infant, you will come to HIV exposed infant evaluation because this child was also exposed to HIV. Enter the unique ID, SUP22F, and get form. This now gives you the exposed infant evaluation form. This child is exposed to HIV, but we don't know if the child has HIV yet. During pregnancy, let's assume that the mother was not, did not register for antenatal until during labor. And then during labor, let's assume that this was the exposure the mother had during labor. The first 6 weeks of life, the child was placed on this. The child is enrolled into care now when the child is 7 weeks old, let's say 7 weeks. The name of primary caregiver, let's put it as the mother's name. The type, biological parent. They have a secondary caregiver, which is the father. The address, so you can put in any address, or the address of the mother, the address of the father. Let's say they live together. And then did the caregiver agree to home visits? Let's say she says yes. Mode of transmission, if positive, this child has not yet been screened, so we don't know if the child is positive. You can put the telephone number of the caregiver here. Gestational age at birth, let's say it was 39 weeks. Duration of membrane rupture, if you have that information, you can put it in here. If not, you leave it. If the child has been confirmed positive, you now want to look at the date of final HIV diagnosis and the type of test and the date enrolled into care and all that. But for now, the only thing you want to look at is the mother of if the child's mother alive, let's say the mother is alive, the father's HIV status, we don't know it yet. The address of father is still the same as the secondary caregiver. And the telephone number of the father. And then we save. Once you are done with the enrollment information, you can now come to the exposed infant screening. So the age attest one. So the form lets you screen at any age. So you try to follow the standard of screening within the countries when the first test of an exposed infant should be done. But this infant was brought at 7 weeks old. The infant is screened today. The date is 16th of March 2022. Let's assume that this test is positive. We save this. So this infant is positive. There is no need to continue the evaluation once the infant is positive. For exposed infants, you don't need to refer. You don't need to refer, you don't need to register into care. Once the exposed infant is positive, you can come to appointment/patient monitoring and schedule appointments for the exposed infant to see the doctor. SUP 22F, reason for appointment, HIV clinical management. The date is today. Then now you come back to the same process. You can go through the adherence counseling. Since we've done the adherence counseling before, I'm not going to repeat that, but it's exactly the same thing as what we did earlier. It's just that this time you're asking the caregiver the questions. We come back to appointment/patient monitoring. We come to create visits or record vital signs. We put in the unique ID of the client again, and we start visit. Now this client is a child. Let's say the temperature is 40 degrees Celsius. The blood pressure is, let's say, 130/65. The pulse is, the respiratory rate is 27. The weight of this child is 7 pounds. The height of the child is 47 cm. The BMI is 14.5. The head circumference is 35. Chest 33. Middle palm 13.5. And then I will send this. Now the care card of the child has been released. So you see the process for the exposed infant. Once positive, you can just go straight to schedule appointment and let the infant see the doctor directly. They automatically enrolled into care, apart from the exposed infant care, once they are positive. You can now come to HIV care card and enter the exposed infant ID. The HIV care card for an exposed infant is exactly the same thing as the HIV care card for a pediatric client. The difference is that the exposed infant has 3 additional forms added to their forms. They have the initial evaluation form, which was filled in, the screenings that show that they were positive, and the immunization form where you fill in the immunizations or any vaccine that is going to be given to the exposed infant. But every other form here is the same thing as the forms we saw on the pediatric care card. Since we've gone through all these forms previously, we will not go through these forms again, but we can now see what we will see here. If this infant is also exposed to syphilis or hepatitis, you come to clinical management and go to other care card. Enter the unique ID and get, sorry, this is previous encounter. Get to other care card, enter the unique ID, get care card. Now for this care card for exposed infant, we have totally different forms. The only form that is the same is the vital signs. The perinatal HIV hepatitis case report must be filled for every exposed infant who was exposed to hepatitis. The perinatal hepatitis clinical and diagnostic data for every child who was exposed to hepatitis. Every baby who has been exposed to syphilis, you fill the congenital syphilis case investigation and report form, and you also fill the congenital syphilis clinical and diagnostic data form. The treatments treatment monitoring, and immunization is the same form we have the HIV care. Any question? So again, for exposed infants, once you register an exposed infant into care, and the exposed infant is exposed to HIV, you do the exposed infant initial evaluation. If the exposed infant is positive to the HIV screening, you can go straight to continuing the steps from getting an appointment. For exposed infants, HIV takes precedence also. If you register an exposed infant for HIV care, you automatically get the TB form, but you don't get the hepatitis and syphilis form for exposed infants that's on the HIV care card. And the reason is we want to accurately fill the forms you want to fill, because most of the time, if you have exposed infant registration, you might be having a lot of infants who are exposed to syphilis, right? And you want to have a care card that deals with just those case reports so that they can adequately treat that case. Now, secondly, for exposed infants that are exposed to syphilis, they might be treated outside of the HIV clinic, and you don't want to release the HIV care card on the others for any other doctor that doesn't deal with the HIV to have access based on how comfortable the mother is, since some of the mother's information will be on that care card. So that's the reason for the exposed infants. For exposed infants, there is no double referrals or registration. You will do one registration and all the care cards are available. The only difference is that you have to go to HIV care card to get HIV and TB care card, and you have to go to other care card to get care card for hepatitis and syphilis exposure. Does that answer your question, Andrea? Okay. So here is the form for the case, congenital syphilis case report. If you try to register an exposed infant, you can navigate through this form and see the information it holds. So regardless of if the infant has this condition or not, as long as the infant is exposed, you want to fill these forms so that you can actually contribute to your EMTCT report. Now, we have looked at general population counseling and testing functionalities. We looked at how to create a client account, how to request release of a client's file, how to collect client information, and how to retrieve screening history of a client, how to update just the personal information of a client, how to look at all pregnancies that are registered at your current assigned testing site, how to look at all the records that you have accessed on the system, how to record self-test kits distribution, to view all HIV screenings at your current assigned site, to also get reports, exportable reports, or view all reports of syphilis screening at your current site, all tuberculosis screenings at your current site, and all other screenings done at your current site. This functionality for general population counseling and testing should be assigned to all VCT providers. Optionally, you can assign this to a lab or just give the lab updates permission so they can only have access to the screenings they want to update. You can also decide if you want to give this to the doctors to have access to everything apart from CMS and pharmacy so that it becomes easy to do other functionalities without having to call the health centers. The referrals permission should be given to everyone who has the general population counseling and testing permission and who is also in the clinic. For referrals, we refer clients for HIV care if the client has HIV, regardless of the other conditions that the client has. We refer clients for TB if the client does not have HIV but has TB. We refer clients for other treatments and management if the client doesn't have HIV, doesn't have TB, and the client has hepatitis or syphilis or other STDs, or we want to refer these clients to be placed on PrEP or PEP. The next functionality is the care registrations and initial evaluation, which should be assigned to the clinical management team, the clinical care nurse, the doctors, whoever is going to be at the point of registration of referred clients. Under this functionality, you have a link to view all of the HIV referrals, a link to view all of the TB referrals, and all of the referrals for other care and for prevention. You also have a form to register HIV, syphilis, and hepatitis exposed infants. You have a form to register adolescents, adults, and pediatric HIV referred clients. You have a form to register TB referred clients and a form to register clients referred for other services. Once you have registered your clients, if the category of the client is an adult and the client was registered for HIV, you come to adult, pregnant, and adolescent initial and clinical evaluation, which means that even if the client was pregnant or adolescent, you're going to use the adult, pregnant, and adolescent initial and clinical evaluation. If the category is pediatric, you'll use the pediatric initial and clinical evaluation. And if you had registered an exposed infant, you're going to use HIV exposed infant evaluation. So if the exposed infant was registered and the exposure includes HIV, you will do the HIV exposed infant evaluation. If not, you can optionally skip this exposed infant evaluation since the client or the child or the baby is not exposed to HIV. If you want to get a list of all the clients that are registered for HIV care, you click on registered clients. To get a list of all the clients that are registered for tuberculosis, you will get tuberculosis and all the clients that are registered for others. This list gives you the list of clients, not the ones in TB care, but the ones whose primary entry purpose was TB. So even if they get HIV later, you will find them under registered HIV clients. But if an HIV client later gets TB, you are not going to find it here except you do a referral and registration. And you won't need to do that because the HIV gives you access to TB forms. So whenever you look at this registered TB client, the system is telling you that you are looking at the list of people whose primary purpose of referral was tuberculosis. And if they got HIV along the line, you will find them under HIV registered clients. Registered clients orders will only give you a list of those whose primary purpose of referral was for prevention or other STDs. Any question?
Oh, please.
Okay. So we have the prevention and control / PMTC team, and we looked at this yesterday, where you can track clients' risk history. If you want to look at the risk behavior of a client and you want to look at the last 3 recorded risk behaviors, you're going to click on this. Yes, someone raised hand.
Yeah, just before I go forward, something that I noticed when I was inserting information for the case studies, even though the site was not idle, what happened is that at times when I submitted the information, it bumped me out and something on a pink line with black writing came up and said that I did not have access or something along that line. So why would something like that happen?
Okay, so even if you said you weren't idle, the system did not detect any mouse movement on your page, and so it will log you out. Because there is this pattern of people that happens in the US, right? They don't want to automatically be logged out. So they'll put a teacup or something in front of the camera, and the system begins to feel like somebody is there and never locks them out. So now there's this pattern of it counts down to 5 to 5 minutes of inactivity, and the inactivity that this system uses if there's no mouse movement or any activity on the page, even though you are active, but you're not moving your mouse or you're just reading the page, it will log you out.
Okay, thank you.
So you track clients' risk history by clicking on track risk history, and this gives you the behavioral risk history. The last 3 recorded behavioral risks. Risk reduction, you use this to fill in your risk reduction sessions if you are placing a client on a risk reduction plan. And if the client is on risk reduction, you want to look at the session history or the history of the forms that were filled from previous risk reduction sessions, you click on risk reduction history. If a user is a contact tracer, listed contacts will give you the list of all of those who were listed from different health centers across the country that are at risk or were listed by somebody who is either positive or has a very high risk behavior. Report tracing is the link you use to report your tracing activity for a listed contact. If you are a prevention officer and you do not have general population counseling and testing permission, you only have prevention and control, and you have a client who you are going to see for prevention, and the client has a very high risk behavior, and you want to refer the client for pre-exposure or post, you use PrEP or PEP referrals. This will automatically give you the form for other referrals where you refer the client to be registered for the exposures. If you want to get the list of all of the contacts who are listed by other clients and that are not yet traced or the tracing is not complete, you go to untraced contact list. If you are the PMTCT coordinator, you want to monitor that all pregnant, reactive, or positive clients are in care and are getting treatment. You use the pregnant client registration form to look at the alerts and get the PMTCT data form to see if the client has started commenced treatment for either syphilis or HIV. If you want to look at the PMTCT registration history to see if a client started treatment and when, you go to the PMTCT registration history form. The next tab is the screenings category / mortality update form. And we have not looked at this, and we're going to look at this now. If you have the updates permission, you will have access to this menu. Under this menu, you can order or update screenings. If a client comes, you don't want to go through the process of retrieving forms, or you give this permission to the lab, you don't want them to have access to the whole file of the client, or the lab to go through the process of retrieving and going to collect information, you give them this update permission. They have this, they click on order / update screenings, and then enter the unique ID of the client, and then it gives them just the screening forms for them to update screening results. So they don't have to go through any long process. And so even if you're at the health centers and you have a day where the lab brings in bulk results for confirmatory tests that were requested, you can use the update permission to go into each file and update their results without having to go through the long process of asking for retrieval of file, go to collect information and scroll through all the tab. You can come straight to screenings category and mortality updates and select the order or update screenings, and that gives you just the screenings form for you to update screening results. Then if you enter the client category in error and you want to switch category, or if a client was registered as a pediatric client and the client is now an adult, you can come here to switch the category of the client from pediatric to adolescent or adult so that the system can regenerate the appropriate clinical management form for the client. Also, if a client dies, you can come back there to register deaths. And somebody made a suggestion previously that the death should be registered and the date of death. So I'm going to add that here. I have not done that yet, but it's part of the list of outstanding recommendations that I will do. So you put in the status if the person is alive or dead, and the cause of death. Here it is HIV related death. And you are going to find a new link here before the end of the week of the date of death of the client. So this is the shortcut to update screenings and registered deaths, and also to update client's category or to switch the category of the client. We look at psychosocial support and adherence counseling. The adherence counselor should have both the routine permission and the psychosocial support and adherence counselor permission. And they have access to schedule counseling appointments if they want to give an appointment for the client. Let's say this client has gone through adherence readiness assessment. The adherence counselor cannot really place the client on the list of ready or not ready, but wants to get this client ready as early as possible. Then just scheduling appointments for adherence strategy work plan. And once you schedule the appointment, then as the adherence counselor, you come back to your menu and you look at the list of pending counseling appointments. You should find that ID on the list of clients who has pending appointments, and the appointment is for adherence strategy work plan. And don't worry about the ordering. While I'm uploading the live system, I'm going to make sure everything is ordered either alphabetically by unique ID or by date of schedule or by purpose of appointment. So there'll be a proper order for you to easily search. Now, once you have the clients with an appointment, you can come to start counseling encounter, enter the unique ID. The system automatically generates forms based on the purpose of the appointment. And since this client is here for adherence strategy work plan, the form has just 5 questions. And what the form basically does is to do a simulation of a medication, maybe multivitamins or supplements, at the same dosing with the intended ARVs to see the client's commitment or attention that is necessary for the ARV medications, and to see how ready the client is. So you can do this for 2 weeks, depending on the client's CD4 viral load or how the timeline is within the countries, what the practice is, and see if the client is adherent to the practice before placing the client on ARV. So you fill this form on what you are doing for your adherence strategy and save it. And when the client returns during the next visit, you want to do a follow-up assessment of this practice or simulation of the attention the client needs. When the client comes back the next visit, you are going to schedule counseling appointments, but this time for adherence follow-up assessment. And you will schedule adherence follow-up assessment only for clients who were prescribed medication for you to see how many doses they missed, if the medication should continue or should stop due to severe non-adherence, and you want to see what their concerns are or difficulties in not taking medications. Once you are done here, you can come to past counseling encounter. And if you want to review previous sessions that was filled in during an adherence session, you will come to past counseling encounter, enter the unique ID, and it gives you the 3 types of counseling and the values that were filled in previously. So this person has only had a pre-treatment adherence counseling, and you can see what was filled in during that session. So the system does not overwrite any form. You always have the history when you want to retrieve previous encounters on the system. Then these are all the functionalities for psychosocial support. The next is the appointment/patient monitoring. This is the part of the system you come to when you want to schedule any appointment. So if you want to have a structured system where you want to have a defined number of clients for a clinic day, so that you don't overwhelm the clinic visit and you'll be able to collect complete data, you might want to always use appointments to make sure that clients with appointments have priority and the clients without appointment, even if you want to attend to them, they will have to understand that they came on the day they have no appointment, so they can't complain about the wait time. So you want to give the appointment, and you are going to view pending appointments using the view pending appointments, and you see the list of all those who have an appointment. There are clients who will remain on this list for a very long time, and those are clients that have missed their appointment. So if you see the date of the appointment is past and the client has not showed up, you might want to follow up now with these clients. Whenever they come, they can use this appointment regardless of their date, even if the date is past. So all you can always do is that if you call them to follow up on the missed appointment, you can always come back to appointment/patient monitoring, and you can come to update the appointment by clicking on change appointment date. So this time you can enter the unique ID and then change the date of the appointment from the past date to a new date. Then we have the appointment monitoring/patient monitoring. And this is also the place where you come when a client comes in on the day of the appointment. You come to create visit/record vital signs. Now, this is where you must always create a visit for any client who is there for HIV management visit, or the care card will not be released. For every client, regardless of the category, who comes in for HIV management, they must have an appointment, and you must create a visit before the system releases their care card. If you want to monitor, so if you're a supervisor in the clinic, at the clinic level, and you want to look at the adherence readiness information, or you're a counselor with the patient monitoring permission, you can come to get adherence readiness. Yeah?
I just want to make sure I get you. Okay. So the patients have an appointment to see doctor today. All the baseline works are done already. The patient was here before, but they have a visit for today. You don't have to go through the general population and counseling to retrieve the patient file. You just go straight to create an appointment, a visit.
Yes.
Okay, then, thank you.
So no, if the patient already has an appointment now, you go to create a visit. If the patient comes and there's no appointment on the system, you create an appointment before visit.
Thank you.
Okay. So you want to monitor and make sure that patients are followed up and nobody is lost to follow up or nobody is adherent. You come to get adherence readiness information, and then you see the list of those who were assessed by the adherence counselor. You see their unique ID and the kind of assessment that was done. So those who were done with go through psychological assessments, you have them and what the psychologist or the adherence counselor has said, whether they're ready or not. Those who were ready through strategy work plan, you find the list of the clients here who were not ready psychologically, but when they went through the strategy work plan, they were able to be adherent to the simulation done. Then you also have a link where you can monitor clients. And this monitoring is for 3 different purposes. You want to see those who missed appointments, those who are not adherent to the medications prescribed, and also we want to look at the CD4s and viral load, those who has never had one, those who have had one and too long ago, and the date of the next one. So this one gives you the unique ID of the client, the date of the last CD4, the date of the next CD4, the date of the last viral load, and the date of the next. When you see ellipses like this, it means that they have never had the test done before, and so the system cannot generate a next date without having a test. For medication adherence assessment reports, you're going to get this report only when your clients on ART were assessed and their medications were reviewed to see that they were adherent. Maybe you did a viral load test and the viral load is going down and there is no indication of any failure or any need to suspect that they were not adherent. the adherence counselor will fill in their follow-up assessment form, and you'll see what the adherence assessment report is here. Here you'll see the list of all those who have missed appointments. So anybody whose appointment was days before today will be on this list. And so you can use this list now to try to contact the clients to make sure that you get them back into care, or you want to find out their reason of missed appointments, and you can now reschedule the appointments for a more convenient date where they can come in. The last functionality under appointments/patient monitoring is the routine test. And this routine test gives you color codes of the screenings. And the routine screenings by this definition is just CD4s and viral load monitoring. All the tests that have passed or have never been done will be in red. Those that have been done and have the next date in the future will be in green. But what is very important on this form is for you to be able to reset a client's CD4 dates here. If in your country you are not using CD4s every 3 months or viral load every 6 months, and for any reason you just don't want to see the system flagging the 3 months due, giving you a red flag for a client whose last CD4 was 3 months ago, and is telling you the client is due, and in your country you use 6 months, this is where you come enter the client's unique ID, CD4, and reset the date. So that way your system removes the flags for the CD4 and gives you another 3 months before another flag is generated. So you can choose to do this or choose to ignore the flags if you don't use 3 months and 6 months intervals for testing. So anybody can have the appointment/patient monitoring permission. Anybody, I mean anybody on the clinical management team. Clinical management is the functionality that is strictly for the doctors who manage HIV, TB, other STDs, or hepatitis. There are also functionalities that you grant to doctors who see clients for prevention, maybe PrEP or PEP. This has 5 functionalities: a link to view all the clients who are waiting to see the doctor. Vital signs have been taken. They are done with the nurses. They're just waiting for their turn to see the doctor. HIV care card is a link that gives you access to HIV care card of clients who are registered for HIV care. TB care card for clients whose primary purpose of registration is tuberculosis, and other care card for clients whose primary purpose of registration was for prevention or other STDs or hepatitis. The system automatically gives you forms based on the category of the client. Adult for adult, pediatric for pediatric, and exposed for exposed. Once you fill in encounter forms, yeah, someone talking?
Children,
Yep.
yes, you were saying that the clinical management, these responsibilities are for the doctor, right?
Yes.
But is the nurse who had to fill out the certain parts of the card? What about her?
What part of the card does the nurse fill in for clinical management?
She don't have to do the vital signs and so?
But you do the vital signs when you create visits, right?
Okay,
Yeah.
so okay, all right.
Yeah, so for that, you just do that under appointments. So the nurse who gives the appointment, when the client comes, the nurse who creates that visit under the appointment. And so it's when you create visit that you do the vital signs and other statistics. And once you do that, that is when the care card for HIV is released, and the clients will now be on the list of waiting clients.
Yeah. Okay then.
Yeah. So this is the functionality for doctors, except if in the country there's any need for the clinical care nurses to have access to case notes. You can give clinical management also to nurses. The system is not strict, but the functionality is just designed for all the clinical management notes. Okay, so clients who are registered for HIV care, regardless of if they have other care registration, you can use HIV care card to access all. For adults, HIV care card to access HIV and TB care card for pediatric, HIV care card for HIV TB for exposed. TB care card for clients whose primary purpose of registration is TB and they do not have HIV or other STDs. Other care card for clients whose purpose of registration is for prevention, other STDs or viral hepatitis, and they do not have any other condition. Previous encounter is the form you use when you want to retrieve the past recordings for a client. So most of the forms for clinical management are encounter forms where if you put in any values, the form clears out. But when it comes to previous encounter, you put in the unique ID, it gives you all of the case notes that were previously filled in for that client. And so this is where you retrieve all of the previous entries because the care card do not hold previous entries. Previous entries are found on that previous encounter. We do not need to do vital signs to get this. So if a doctor sees a list of appointments and they just want to review the previous encounters, the previous symptoms, the previous treatments of a client, before the client walks in, they can do that by previous encounter without going through all the processes and wait until the client has an appointment or has created a visit and is now ready to see them. Then they retrieve the care card after having knowledge of the previous, especially if that doctor was not the doctor who saw the client previously. Question? So we looked at central medical stores and supplies. And for central medical stores, we looked at the list of registered pharmacies dispensing ARVs. You can use it for other purposes. If you don't have a pharmacy information system or central medical stores do not have a system, they can use this for other purposes outside of HIV also and record all possible drugs. The list of registered pharmacies just tells the central medical store the pharmacies that are registered on the system that they can record distributions to. Any pharmacy not on the list, they cannot record the distributions on the system. So if there's a pharmacy they distribute to, they will need to have that pharmacy name registered on the system, regardless of whether the pharmacy is private or public, or regardless of whether the pharmacy dispenses ARV. It just needs to be there so that the central medical store functionality can be complete in the events that the central medical store is using this system as their major stock entry and stock control system in the central medical unit. The central medical store creates their medication stock, and creating their stock automatically creates the list of medications available in the country. It doesn't matter if a private lab has it. If the central medical store doesn't have it, it is not going to list that medication in any pharmacy in the country. The stock list gives you a list of all the stock that were entered into the system that the central medical store currently has, and all the batch number, expiry date, the quantity, the strength, and everything about the medication. Anything on this list is currently in stock, and you see their quantity. Until the quantity becomes 0, then it's off the list because it's no longer part of the stock. The central medical store also can recall a drug that is in stock. So recall, by the definition of this system, is to delete a stock from the list of stocks if the stock is expired and you want to take it out of the list so that you no longer distribute that drug. If it is defective or potentially harmful and there's a reason for you to remove that from the list because you no longer distribute that, or there's an adverse drug reaction that has made you stop, or pharmacies are no longer ordering those drugs. If it's out of stock and it was entered in error, if a manufacturer recalls, you already have it in your stock and the manufacturer recalls the drug, you'll use the recall to take it out of your stock. And if you enter it in error, you want to delete, you also use recall and select your reason as error and click on the recall button. Only when you fill in this recall selection, will you need to use the red record button? If you fill in other parts, you will need to use the green edit button. Yes, Dr. Peters?
Mildred, on the previous page, you said that if the stock is 0, the medication automatically is removed from the page. Is that
Yeah.
right?
Yeah, the stock is 0. You don't have, yeah, it's removed from the list of stocks, yeah.
But you would need to know that you have 0 in that stock for you to order. If it's removed, then it may be lost. The information may be lost, or the note